morning, everybody, and thanks for the privilege of presenting Grand Rounds for you today. I want to discuss a topic that is a little bit heavy, gun violence today, and hopefully over the course of this discussion I'll be able to convince you that we as surgeons actually have a role as leaders in what I think is a public health crisis of firearm violence. And I think that's actually a direct extension of our care that we provide to patients every day here at UC Davis. I don't have any financial disclosures to make. Thank you, Dr. Loesch. I don't have any financial disclosures to make, but I do, however, have a disclaimer. I recognize that this might be a controversial topic, and discussions about gun violence can evoke some strong emotions. It can quickly devolve into a rehashing of some ideological and political talking points, and I'd like to avoid that during this discussion. Really, I'd like to focus, as a group of physicians and scientists here, on the data that we have available to us regarding the epidemiology and attempts at curtailing gun violence in our society, and see if we can focus on finding some common ground that we can all stand on together to make a safer world for ourselves, our patients, and for our loved ones. So today, I'd like to begin by covering the epidemiology and some unique social factors at play in the demography of gun violence. And I'd like to discuss some of the history regarding the trends in firearm violence and attempts we've made here in the United States at reducing it. I hope by the end of the talk to have convinced you that gun violence does constitute a public health crisis, and that as such it might be amenable to public health approaches at cessation. And finally, I'd like to explore the unique role that we as surgeons have, both in general and specifically here at UC Davis, in an effort to make an impact in the health of our community that we were served with regards to firearm injuries. So when I was deciding what I wanted to talk about for Grand Rounds, I wanted to pick something that would be relevant to my career in trauma moving forward, something that I didn't know everything about. I wanted to educate myself a little bit. I wanted to pick something that would be relevant to the current climate and something that might be of broad general interest to everybody. And as I was doing research, I kept getting sidetracked, reading about these terrible mass shooting events. I couldn't get away from it, and it turns out it's everywhere, omnipresent. It's hard to go any duration of time at all without reading or hearing about another mass shooting event, just another one a couple days ago. And so I knew that at that point, reflecting on this, I had to use the soapbox of Grand Rounds to talk about gun violence. I thought it would be an appropriate time. The personal impact that these horrific events have on patients, families of patients, the psychological toll it takes on survivors, the sense of terror that it instills in the public is devastating. And each mass shooting affects us all in terrible ways. And they have almost essentially continuous mass media coverage it's impossible to get away from. And the sheer number of mass shootings in America really is mind-boggling. While Americans make up about 5% of the global population, over 30% of mass shooting events happen here. Using the strictest definition of a mass shooting, which involves 3 victims exclusive of the shooter, in the United States last year we had almost 350 mass shootings. This resulted in about 600 deaths and almost 2,000 non-fatal injuries. And the trend's continuing this year with already, as of yesterday, 134 mass shootings. And beyond the immense toll that gun violence takes on its victims, there's an additional societal impact with a growing public concern about falling victim to gun violence. In 2013, the survey was done in which 42% of respondents said they had a daily concern about falling victim to gun violence. Just to put that into perspective, more people in this survey were worried about being shot every day than they were about losing their jobs, being victims of a terrorist attack, or being unable to pay their mortgage or pay their rent on time. So it's a big concern in the mind of the public. And this growing concern is shaping the political dialogue. Record numbers of people are citing guns or gun control as the #1 issue facing Americans in a recent Gallup poll. Historically, this figure has been around 1% since 2001. And just in March of this year, that number was up to 13% of people thinking it's the most pressing issue facing our society. And despite the truly terrible effect of public shootings, the most sobering thing about this is that consistently this makes up less than 2% of the deaths from gun violence every year. Well over 30,000 people are killed with a gun every year, and that averages out to about 105 deaths daily. And contributing to this fact is the idea that firearms represent a particularly lethal form of violence. Suicide attempts with a gun account for a relatively small proportion of all attempts, around 6%, but they're accountable for about 51% of the actual deaths. And suicides make up about 2/3 of all deaths from gun violence. Stated another way, of suicide attempts that don't involve a gun, about 93% will not result in death. So guns are particularly lethal. And similarly, gunshot wounds that are not self-inflicted are about 20 to 30% deadly, which is much higher than other forms of interpersonal violence. About 17,000 people are fatally assaulted every year in the United States, and around 75% of these are with a gun. And there are clear differences in the demographic distribution of gun-related deaths. Firearm homicides are disproportionately affecting young black men. Black Americans make up about 14% of the United States population, but they account for more than half of all gun deaths, or of all gun homicides. And gun violence is almost exclusively the killer of young black men ages 15 to 24. It's about 90% of the deaths in that demographic, and is more responsible for death than the next 9 leading causes of death in young black men combined. This graph focuses on men, I recognize, and about 3/4 of homicide does involve men as both perpetrators and as victims. While women comprise about half of the United States population, they're the perpetrators in homicide in less than 15% of cases, and similarly are less likely to be victims, around 25%. It does bear mentioning, however, that specifically there's an increase in women as victims of homicide when we look at intimate partner violence or homicide that occurs within the home. Women bear a relative risk of about 1.3 compared to men in being a homicide victim in these specific scenarios. In fact, it's rare for a woman to be killed by a stranger. A woman is about twice as likely to be killed by an intimate partner or a close relation than she is by a stranger. Suicide has a unique demographic as well. Similar to homicide, men are about 4 times as likely to die from a suicide than women are. And while women attempt suicide about twice as often, the death rate is much higher in men, and they're much more likely to use a gun in a suicide attempt. In contrast to homicide, suicide by firearm is much more common among middle-aged and older white men, and white Americans consistently have the highest suicide rate when stratified by ethnicity. The suicide rate in white men is about 2.5 times that of black men of similar ages. The recognition of these unique demographic factors can help us in our ability to identify patients who are at risk for firearm violence and counsel them appropriately in clinical encounters. Looking at the trend of the death rate over time in America, it appears on the surface, when we compare ourselves to the peak of violence in 1993, that we're doing a pretty good job. The death rate's dropped by about 50%. But when we look a little bit more closely, I've got a nice tremor. So the death rate has held steady for about the last 2 decades. And you can see that there has been a slight decrease in the homicide rate over the last couple decades, but that's more than made up for by the increase in suicides over that period of time. In fact, there's been about a 19% increase in the suicide rate in America over the last decade. You can see that uptick since about 2008. And interesting fact that the continued and pervasive problem of gun violence, when we look at 1968 on, there have been more deaths from guns in the United States from suicide and homicide than in every war, in every battlefield that the U.S. has ever been involved in, ever. It's an incredible number of lives lost. And the sheer number of gun violence deaths is mind-boggling, but when we consider the non-fatal injuries that occur, the scope of the problem is much larger. Estimates vary between 2 to 3 times as many people are non-fatally injured with a gun than there are die from gun violence in the United States. In addition to the direct impact of life and limb lost from these incidents, there's a staggering economic cost to society as a whole, annual attributable cost of about $230 billion a year from gun violence in the United States, as it disproportionately affects young people and the years of lifelong medical care and productivity lost really affects our society. And we talked a little bit about how gun violence is essentially omnipresent in the minds and the media in American society. It's interesting to note that it really is a fairly uniquely American phenomenon. Comparing ourselves to similar Western and industrialized nations, Violence is an incredible problem in America. We look at our neighbors in Canada, our homicide rate here is about 3 times that of the Canadians, and almost all of those excess deaths are due to gun violence. We have a few more non-gun deaths, but there's a staggering increase in gun deaths here, and that might not be surprising when we look at the preponderance of guns that we have in the United States. Estimates now say we're up to probably about 1 gun per person in the United States, and that far outpaces the next closest country, which is, I don't know if you can read that, that's Yemen, which you may know is currently embroiled in a civil war. We have more guns here than a country actively in civil war. And looking specifically at gun-related deaths in America, compared to 23 similar industrialized and economic powers in the world, this is using 2003 data, America continued to be an outlier at that time. With regards to homicide, suicide, and accidental deaths, the United States has a substantially increased relative risk, and this effect is preserved across all gender and age categories. In the study here, about 80% of the deaths noted were Americans, despite looking at 24 different countries. And in another study using 2010 data, they took a closer look at kids specifically. This is really sad. The demographic of 5 to 14-year-old kids, who essentially by all accounts are innocent. This continues to reflect the disproportionately large impact of gun violence in our society. Our own children are more than 14 times more likely to be killed by a gun than in any other major industrialized nation. In fact, about 90% of the deaths included in this study, again looking at 24 countries, were from the United States. It's a staggering problem. This risk is contributed to by an elevated risk of homicide, suicide, and accidental gun deaths. And clearly there's something wrong here. Gun violence is affecting essentially every demographic. It crosses economic boundaries, has a visible public impact, and there's an enormous personal and societal toll from this problem. And things we're doing now are not making it any better. The death rate's been stagnant for about 2 decades, so something more needs to be done. Something has to change. So, segue to public health, described by the CDC, it's the art and science of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. Public health is really interested in harm reduction, and it focuses on primary prevention more so than secondary interventions. And it relies on recognition of a broad problem that has shared responsibility for finding solutions. I think gun violence is a big enough and complex enough problem that we all need to take some responsibility for finding a solution. And I'd like to make the pitch that I think public health methodology might be a vehicle that can allow a number of participants to collaborate. Look at gun manufacturers, distributors, owners, gun safety trainers, physicians, police, attorneys, universities, and teachers, the Surgeon General, politicians, our faith communities, hairdressers, corporations, and unions can all collaborate in this space to really address such a massive problem that gun violence presents. It's not just about changing laws. I think it's about changing social norms for something this big, and it's going to take a village to tackle this problem. That sounds very appealing. I understand it. You might be wondering how practical this can be in getting all those people together, or if public health approaches can even be effective or applicable to the problem of gun violence. I like to use the case of car crashes to make a statement to you, illustrate how public health interventions can work, and I'd like to make the case that a similar approach might be used for firearm injuries. So this is staggering. You'll see here. In the 1950s, deaths from car crashes far outpaced that of deaths from firearm injuries. And through a series of public health interventions, we've reduced the number of car crash fatalities to roughly equal that of gun violence deaths in America today. Motor vehicle crashes have decreased since that time, and the fatalities have decreased by about half since the 1950s. And I think the most important point to recognize is this was all done without taking away anyone's cars. There are ways to make things better without taking away people's cars, without taking away people's guns. People are actually driving more than they ever have, and while the death rate's dropped by about 50%, If you look at the death rate per mile driven, it's actually down 85% since the 1950s. And as I stated, currently there are as many firearm fatalities as there are motor vehicle fatalities, and this process didn't occur overnight. It's taken a series of public health interventions, research, data collection, and analysis to see which interventions have been effective. And it's really an incredible accomplishment. It's actually hailed as one of the greatest accomplishments in public health by the CDC of this decade. In the 1950s, the focus of intervention on car safety was really on the driver. It was reasoned that if car crashes were the driver's fault, if we could just improve the driver, then there shouldn't be any more crashes, right? If everyone obeyed the posted traffic rules, didn't drink and drive, if they avoided speeding, in theory there should be very few deaths from car crashes. This prompted increased attention on educational interventions such as driver's ed. I think we all went through that, or those terrifying red asphalt videos that I still have nightmares about. But these were really designed to scare kids into behaving. And it was accompanied by an emphasis on enforcement of traffic laws, DUI citations, and this approach really just wasn't successful in reducing death from car crashes. Segue to the late 1950s, early 60s, public health experts and physicians changed the question from who was the cause of this crash, really, to what was the cause of death. Prompted recognition of steering column injuries, ejections, lacerations from windshields that were not made of safety glass, collisions with lampposts and trees that were just posted immediately alongside the road. Drivers are no better today than they were in the 1950s, but we've seen dramatic improvements in vehicle safety features, road safety, the EMS systems, and this has translated into dramatic decrease in death from car crashes. Individuals are difficult to change, and personal interventions really aren't cost effective, but engineering a safer system can have sweeping effects on our ability to reduce fatalities. And car safety is certainly not the only example of a successful public health intervention that we have. Recognition of tobacco as a health hazard and the subsequent public health anti-smoking campaigns have resulted in changes in social norms, as we talked about. This has prevented initiation of tobacco use in kids, has promoted cessation in use in the already tobacco users, and has reduced environmental exposure to tobacco smoke. Since the 1964 Surgeon General's report on the health risks of smoking, the prevalence of smoking among Americans has decreased and millions of smoking-related deaths have been prevented. Work-related public health problems, such as coal workers' pneumoconiosis, or the black lung, and silicosis, which was common at the beginning of the century, have come under much better control. Severe injuries and deaths related to mining, manufacturing, construction, and transportation have decreased, and since 1980, safer workplaces have resulted in a reduction of about 40% in the rate of fatal occupational injuries. At the beginning of the 20th century, infectious diseases such as smallpox, measles, diphtheria, and pertussis were widely prevalent. There were very few effective measures preventable and death tolls were high, but the development and promotion of vaccines against these now preventable diseases has resulted in dramatic declines in morbidity and mortality, and even resulted in the eradication of smallpox. And those of you may know, that's my kid just after his vaccinations. I had to put a picture of him in there. We've applied these lessons that we learned from public health really to our own practice of medicine. To Error is Human, I think, is a report that we're all familiar with. And that's really shifted the focus and application of public health to ourselves in our practice of medicine to engineer a more robust system and reduce physician and nurse error in the hospital. So we even apply this to ourselves. I think firearm violence may be a similarly considered effort. And with the unique areas for intervention and safety training, violence reduction overall, firearm manufacturing and distribution, and bystander response all may have a synergistic effect in saving lives. So, opportunities for intervention. I think surgeons really are uniquely positioned to address this issue. And the firearm mortality rate has held steady over the last decade despite improvements in the care that we give in the realm of trauma, likely because the majority of firearm deaths really occur before people ever get to us. About 70% of people who get shot and die where they get shot, not here in the hospital. We're actually pretty good at saving people. But surgeons are also uniquely trained or qualified to train civilian bystanders to respond in an emergency. And we frequently encounter patients in our clinic who are at risk for gun violence, display a number of factors that put them at risk, and we have a unique opportunity to counsel these patients in order to prevent future incidents of violence. The prior success of public health in multiple arenas has relied on high-quality research, and as university surgeons, we're at a level 1 trauma center. We have unique resources available to us that we can bring about to generate the data to make necessary, informed decisions. And finally, we occupy a position as leaders, as surgeons, both within the hospital structure and within the public sphere. We can serve as effective advocates, individually and along with our professional societies, to advocate for changes that can save lives. In April of 2013, the American College of Surgeons convened a working group in response to the Sandy Hook Elementary School shooting. And in collaboration with others in the medical community and representatives from our federal government, the National Security Council, U.S. military, FBI, and various governmental and non-governmental EMS organizations, they developed 4 different reports that were called the Hartford Consensus. And one of the recommendations in these reports called for the training of immediate responders. This started the bleeding control program that's you've probably heard a lot about. It's really pushed by the ACS Committee on Trauma now. And it's a program designed to teach the public how to respond to a mass casualty incident. It's gained support from the White House in 2015, and the Stop the Bleed awareness campaign was launched. And since then, over 15,000 physicians have become instructors, including many people in this room, and over 125,000 civilians have been trained how to respond in an emergency. Our own residents have really stepped forward in teaching UC Davis sponsored bleeding control courses, and we offer those regularly for the community free of charge. There's always room for more instructors if anybody's interested in getting involved, and I think it serves as an excellent way to be involved with the ACS Committee on Trauma, educate the public, and really to answer our mandate as a level 1 trauma center in providing outreach to our community that we serve. So in addition to public education, I think there's a role for the personal education of patients regarding safe firearm practices. There's been concern promulgated in the popular media that there may be state or federal laws prohibiting physicians from talking to their patients about safe firearm counseling. Headlines regarding physician gun gag laws can largely be traced back to a single specific incident that came from a small town of about 50,000 people in the center of Florida. Amber Ullman was a 26-year-old mother of 3 who was bringing her youngest child, 4 months old at that time, to see her pediatrician just in a routine well child examination. And during that visit, she was asked about whether or not she had a firearm in her home. She didn't feel it was relevant to the care of her kids, and so she declined to answer. And in something that I think we can all agree was probably inappropriate, she and all of her kids were discharged from that physician's practice, told she needed to go find a doctor somewhere else in another community because it's a pretty small town. There weren't a whole lot of pediatricians. This resulted in a complaint to her local representatives, and multiple similar anecdotal reports surfaced, including one from a state legislator who had a similar experience. This resulted in the introduction of a bill in 2011 known as the Florida Privacy of Firearm Owners Act. And this act was widely publicized as making it illegal to have a discussion between physicians and patients regarding firearm ownership and safety. In reality, the clause in the legislation prohibiting written or verbal inquiry about firearm possession was really tempered by a clause that had an express exception that physicians can ask if they in good faith truly believe that it was relevant to the care of the patient or other people, but it was blown way out of proportion in the media, and there was a lot of concern that we weren't going to be able to talk to our patients about safe firearm practices. So physicians fought back against the perceived attempt to restrict counseling ability for patients, and in February 2017 there was a 10-1 ruling by the 11th Circuit Court of Appeals, and that overturned the act. As it stands today, there are no federal or state laws that restrict physicians from asking about firearm ownership if they think it's relevant to the care of the patient. And there are also no laws preventing disclosure to law enforcement officials if there is an imminent threat constituted by the patient. So while this seems a little bit vague, there's a clarification in a letter from the U.S. Health and Human Services that provides a healthcare provider, quote, may disclose patient information, including information from mental health records if necessary, to law enforcement, family members, or any other persons who may reasonably able to lessen the harm a patient may cause to themselves or others if they feel it's relevant. And so we're lucky here at UC Davis to have leaders in the field of firearm injury prevention, and we have access to a host of services to help identify patients who are at risk and to effectively intervene to promote the well-being of our patients while maintaining a therapeutic doctor-patient relationship. The Violence Prevention Research Program here, it was run by Dr. Garen Wintemute from the Emergency Department, has a website called What You Can Do. And this outlines, it's just through the intranet, what you can do. And it outlines practices for our physician community and has patient handouts as well that we can use to streamline these discussions to optimize what may end up being a potentially lengthy conversation during a busy clinic day. I've allotted a little bit of time for Dr. Wintemute to speak and answer some questions at the end, so I'll just briefly touch on the general approach that we can take to identify at-risk patients, how to counsel them, and how to intervene further when necessary. So perpetrators and victims of firearm violence often have identifiable risk factors, and these risk factors may even be the reason that they're presenting to healthcare in the first place. There are three main conditions under which firearm ownership and safety is particularly relevant to the clinical encounter. One, maybe obviously, is patients who are at acute risk of violence toward themselves or others. This includes acutely suicidal or homicidal patients, and this can be a little bit more subtle than you might think to suss out. So having a high index of suspicion is always something that is worth doing. Patients who have individual level elevated risk factors are potentially even more subtle and demand a rigorous history when interviewing the patient. But a history of violent behavior, we see a lot of that in trauma. History of violent victimization actually increases risk for a number of these issues as well. Abusive partners, patients who have history of alcohol or drug problems, which I think affect a number of our patients as well, or patients who have poorly controlled mental illness, all elevate their risk for interpersonal and self-inflicted gun violence. Notably, patients who have a history of alcohol-related arrest have been demonstrated to have a 6-fold increase in the rate of being arrested for a violent gun offense. And it's worth bearing in mind that patients who have a history of alcohol problems may be at dramatically elevated risk for firearm violence. And finally, as we talked about, patients in demographic groups that are at increased risk for gun violence include children. They're at elevated risk for accidental gun injury. Young people, or specifically young black men, are at elevated risk for interpersonal violence with a gun. And older adults, or specifically older white men, are at elevated risk for suicide. So keeping that in mind, these groups are particularly at elevated risk, and we may be able to counsel them effectively to reduce some of these, or at least ask the appropriate questions to make sure that we're not missing something. And the appropriate counseling of patients who are at risk for gun violence can really be a daunting task. This is borne out in practice. While many medical professional societies have encouraged contextually appropriate questioning and counseling of patients, actual screening and counseling is pretty uncommon. Looking at a study of veterans who, as we know, are at increased risk for suicide, looking at a group of them who screened positive for suicidal ideation in the clinic, only 15% of providers in the setting documented whether the patient had access to a gun. The barriers to effective counseling really are multifactorial and include apprehension on behalf of the provider potentially due to personal unfamiliarity with guns and gun safety, a concern that questioning might be deemed offensive and damage the therapeutic relationship, and uncertainty about the effectiveness of what may turn out to be a lengthy counseling session during an otherwise busy day. Fortunately, again, there are numerous resources available to interested clinicians regarding the benefits and risk of gun ownership, the basic information regarding safe handling and storage of firearms, all on the What You Can Do resource page. And again, there are extensive resources for providers and for patients in terms of handouts. We can use those to facilitate our discussions. As with many personal questions in medicine, this line of inquiry might bring into focus some deeply held personal beliefs, and it's important that we approach it from a place of respect and care for our patients with an emphasis on education rather than on prescriptive behavioral changes. I think requesting permission to discuss gun safety and providing context for why gun-related questions are relevant to the care of the patient in particular can make it an easier conversation. And in terms of the effectiveness of these conversations, it is admittedly sparse. The field's pretty much in its infancy in terms of knowing what things actually do work. But there are some encouraging results from studies looking at brief intervention methodology. We know that pediatricians who counsel patients and their families on the safe storage of gun ownership do reduce the number of loose guns in the home. It increases the safe storage. And there have been studies looking at decreasing the number of guns in homes of actively suicidal teens using brief intervention methodology. And in the acute setting, we know that using brief interventions can reduce the number of youth who are actually carrying weapons after they're hospitalized for violent injury. And so while there are not any randomized prospective trials to demonstrate which particular interventions are effective or the best way to do it, there's certainly no data to suggest that it's harmful, and there is a suggestion that it may be helpful. And so as daunting as counseling patients can be, it's perhaps more frightening to imagine the encounter with a patient who's in crisis. In times of crisis, it is appropriate for physicians to intervene on behalf of the patient by engaging family or mental health services and even law enforcement if there's a patient who is poses a credible risk to themselves or other people and are unwilling to voluntarily give up their guns. In California, we're very lucky. Not all states have this, but we have access to a firearms emergency protective order, which is a judge-issued order that mandates that the patient or the person at risk give up all their guns within a 24-hour period. They can either surrender them to a police department or they can sell them even to a licensed firearm dealer, but within 48 hours they have to give documentation that they have relinquished their guns. And this is a temporary order that really only stands up until the period of crisis is over. It lasts at most 21 days. And it's something that I think, given the lethality of firearms, both in suicide and homicide attempts, as we talked about, really can buy a period of time until the crisis is over and save lives, getting patients the help that they need. So switching gears, a little bit, a key component to the public health interventions, the field of motor vehicle safety and tobacco use has relied on robust databases to identify areas for intervention and monitor the success of these changes. In 1975, the National Highway Traffic Safety Administration developed the FARS, or the Fatality Analysis Reporting System. And that tracks over 100 different elements in car crashes that result in at least one fatality within 30 days of the accident. It's required a coordinated effort and buy-in from law enforcement agencies, insurance agencies, healthcare providers, and state governments. Similarly, tobacco-related deaths actually have an entire office in the CDC. It's called the Office on Smoking and Health, which is dedicated to data collection to, quote, develop, conduct, and support strategic efforts to protect the public's health from the harmful effects of tobacco use. Conversely, gun violence does not have much of a similar database. The National Violent Death Reporting System, or NVDRS, actually began in 1999, relatively new, as a consortium of 6 private foundations, and it called itself the National Violent Injury Statistics System. They partnered with the Harvard Injury Control Center and the Joyce Foundation and brought the idea to the CDC in 2000, and really only in 2003 did this get pitched as a public system called the NVDRS. And only 6 states were participating at the time this was created. Over time, through multiple appropriations, it's grown to include 40 states most recently, but you can see there are some very large states like Texas and Florida that are not participating. We have huge gaps in our understanding of what's going on with gun violence and our ability to track any meaningful changes from interventions that we might make. This is frequently cited as one of the barriers to effective efforts in gun violence research, and there are ongoing active efforts from many of our professional societies to expand the NVDRS to truly become national. Gun violence funding has been another issue, something that's, this was actually shocking to me when I read about it. So in 1993, Art Kellerman published a paper in the New England Journal of Medicine that quoted a 2.7-fold increase in the risk of homicide in a household that had a gun. Simply an epidemiologic study, but the NRA argued that this was politically motivated and was being used by anti-gun lobbyists to increase gun control laws. So they responded by lobbying for increased gun right protections in Congress. In comes, shortly after this, Dickey. He's an Arkansas representative who was the self-proclaimed point man for the NRA in Congress. He sponsored a provision for during the 1996 Omnibus Spending Bill that was known as the Dickey Amendment. And that stated that none of the funds made available for the injury prevention and control at the CDC could be used to advocate or promote gun safety or gun control. During the same spending bill, the CDC budget for gun violence research was slashed by $2.6 million and reallocated for brain injury, precisely the amount that was spent on gun violence the year before. The director of the CDC at the time, Mark Rosenberg, describes this as a shot across the bow and was recognized as essentially a message that gun violence research was not going to be funded by the CDC anymore. And from that time onward, the effect has been chilling. Gun violence research funding has decreased by about 95%, and currently the majority of funding comes from private grants, university support, and recently in California, a state-funded initiative, all while the CDC budget, you can see, which is this top line here, has gone up. This decrease in federal research dollars has disproportionately affected gun violence research. And compared to the 30 leading causes of death as documented by the CDC, gun violence, way down here, is an outlier with respect to the funding it gets based on the number of lives that it takes. When looking at the total federal funding from 2004 to 2015, gun violence research was apportioned about 1.6% of the predicted amount. That's $22 million over this period instead of $1.4 billion. Stated another way, gun violence killed about as many people as sepsis over this time, but was allocated only 0.7% of the funding that sepsis research received. And this is translated into a direct lack of publication volume. And in this same report from this funding research, the predicted number of studies on gun violence was only about 1,700, or 4.5% of the predicted 40,000 studies that should have been published based on the toll that gun violence takes. With relation to mortality, gun violence is the least researched and second least funded cause of death, just ahead of falls. From 1973 to 2012, the U.S. saw about 2,068 cases of cholera, diphtheria, polio, and rabies combined. And during that time period, the nation saw 4 million gun injuries. Yet during that same period of time, the NIH funded 486 studies of those 4 infectious diseases, while funding only 3 on firearm safety. So the relative paucity of research in the field of gun injuries really leaves many unanswered questions, and some of these might even be fairly low-hanging fruit. The field will be greatly advanced by any inquiry into who's actually using guns inappropriately. We don't know that. How are they getting these guns? We know nothing really about the rigor of the average gun safety control or the gun safety course, and we don't know anything about how much people retain from it. We really don't know if it's actually associated with higher proficiency in firearm use and lower gun injuries. We know very little about any safety measures, whether gun locks, safe storage, smart guns, or any other intervention is effective. And we don't even have basic data to inform policy issues that are being vociferously debated at a national level, such as whether or not arming teachers might make schools more safe. We have no knowledge, no information to inform these decisions. Luckily, again, UC Davis is pretty unique in the fact that we're home to the UC Firearm Violence Research Center, which is a consortium of researchers across the UC system dedicated to defining the problem of gun violence more clearly and finding novel solutions for it. It's the only state-funded gun violence research program in our nation, and again, it's led by our own Dr. Garen Wintemute, who is a true leader in the field of injury prevention and gun violence research. The program has access to funding for small grants for researchers who are interested in participating, and it's an exceptional opportunity to participate in a multidisciplinary and multi-institutional project. And I think it has real potential to change the way that we have that we inform gun policy in our country. And when it comes to policy, public perception is really shaped by a divisive political dialogue. And I think it's driven largely by special interest groups that are not representative of the greater public, which actually has largely compatible views. The stagnant state of funding and the visible political debate can be disheartening for the majority of us who actually want to work to find common ground. Initially bitter opponents, Arkansas Representative Jay Dickey, who is pictured here, and Mark Rosenberg, who was the director of the CDC at the time the Dickey Act was passed, actually bonded over their strong interest in gun injury, and they really came to respect each other despite being on different sides of the aisle for their strong interest in doing what they thought was right. They became close friends until Mr. Dickey died in 2017. And over that period of time, their friendship, they co-authored a number of different articles and participated in interviews together, highlighting the unintended consequences of the Dickey Amendment. Mr. Dickey wrote in 2015, quote, "Research could have been continued on gun violence without infringing on the rights of gun owners, in the same way that the highway industry continued its research without eliminating the automobile. It is my position that somehow or some way we should slowly but methodically fund such research until a solution is reached. Doing nothing is no longer an acceptable solution. And this coming together of former adversaries really, I think, serves as a poignant example of collaboration that we can all embody, and may not be that far away from the truth. Trauma surgeons actually agree. All of the major trauma societies and the greater body of the American College of Surgeons have issued position statements in the last few years regarding the need for surgeons to take a leadership role in the debate for over gun violence, and have advocated to increase funding for gun violence research and for our professional societies to take a place in the policy debate. And as you might know, surgeons can have strong opinions. Even among us, there's considerable agreement regarding firearm policies. Dr. Deborah Kuhl and Ron Stewart conducted a survey of ACS Committee on Trauma members regarding their opinions on a number of issues regarding firearm safety and policy. And they looked at the results stratified based on whether the respondent owned a gun or not. 254 members were surveyed and 93% responded, so a great response rate. And of these people, about 45% said that they thought that having a gun was beneficial and a personal expression of liberty. They thought it was important. And while there was a disagreement regarding a number of different measures, there was general agreement on a few measures that may serve as a common ground or a starting point. They agreed that measures that improve mental health screening and treatment, measures that enforce mandatory prosecution of convicted felons who try to buy guns, anything that preserves the right of physicians to counsel patients on safe gun ownership, and things that restrict firearm access for the mentally ill may get widespread support. And strikingly, 88% of members indicated that the ACS should give high or highest priority to reducing firearm injuries. And these views were largely echoed in a separate survey of the ACS Board of Governors, which represents a broad and multi-specialty group of surgeons. And when it comes to public policy, again, I think the debate is largely driven by special interest groups and does not reflect the largely compatible views of the public. This is a survey published just recently, a couple months ago, looking at 2,000 people, and they were asked about 24 different policy points. And 16 of those 24 proposed policies had less than a 10% percentage point gap in support between gun owners and non-owners. And policies that had the highest overall public support and minimal support gap included universal background checks, greater accountability for licensed gun dealers who can't account for their inventory, higher safety training standards for concealed carry permit holders, improved reporting of records that relate to mental illness, and gun prohibitions for persons who are subject to domestic violence reports. While there does remain significant public disagreement over specific policies, I think the general agreement in many areas can serve as a starting point and really provides room for collaboration to find ways to reduce gun violence while maintaining our civil liberties. So I think we here at UC Davis have privilege to find ourselves in a singular position. We're in the political seat of California with unique access to policymakers that many other places don't have. We're backed by one of the finest universities in the nation, and we're home to the only state-funded gun violence research program in our nation. We regularly work with the chair of this program, who also happens to be one of the leaders in the field of gun violence and injury prevention. We have direct access to him. And our departmental leaders have served in leadership roles for a number of major trauma surgery organizations, and we serve as leaders within the American College of Surgeons as a whole. I think that the time and American social consciousness is ready to start discussing efforts to end gun violence, and we're poised here at UC Davis to truly make a difference in the safety of our patients and to improve the safety as our community of the whole, really answering the highest calling of our profession. Thank you. I'll be happy to take any questions.
Well, Jim, as always, we would expect nothing less than a thoughtful and provocative presentation from you. Well thought out and rigorous. We have a little time for questions, and I know that Dr. Wintermute is here as well. So we'll start with some questions.
Sorry, I saw Dr. Boyd's hand first.
Dr. Boyd.
Fantastic. I think it brought a lot of stats that I wasn't aware of, especially given the bombardment that we're getting in the media these days. So I'd like to ask you, given
you want to answer that, or do you want to put that to your?
I'm happy to make it. Yeah. So I think some of the lowest lying fruit are things that are not going to meet much opposition from people who feel that it's a civil liberty to have a gun, and I think that's important to protect those liberties. There are certainly legitimate reasons, vocational and recreational, to have guns, and I don't think that that's a good place to start. I think that safe storage of firearms is really important, and I think that one of the things that should never happen are accidental firearm injuries to children. That's a relatively small number, but I think that that's something that we can certainly, everyone can agree on should not be occurring. We have very little data to know what are safe interventions or safe ways to reduce those, but I think that largely when we look at people who do end up dying from gun violence, we know that suicide is more prevalent than homicide, and we know that there are specific demographic groups that are at risk. Taking a look at people who do attempt suicide with a gun, who survive, which is again only about 10%. If you ask them why they used a gun, largely the response is, well, because it was available, I had it out. And if you ask them how long they thought about committing suicide, over 60% of people will tell you less than an hour. So these are periods of typically altered mentation. A lot of people are intoxicated with substances, usually alcohol, prior to committing suicide. And I think that having safe storage, or even just a temporary barrier to using a gun to kill yourself, maybe keeping guns and ammo separately locked up or keeping them in a safe, might be just enough of a barrier to get people through a crisis period and protect children.
Right, so just for context, when the CDC looked from 12 to 16, roughly 60% of gun violence was suicide.
Yeah.
So in actual fact, if your target resources, like just what you were saying, the real target, in actual fact, should be suicide prevention and the things around.
Yeah.
Would that be correct?
So I think that's important, but it's also important to recognize the particular lethality of firearms in an effort to kill oneself. We talked about the fact that they're about 90% successful. If you look at the majority of suicide attempts, it's either through toxic ingestion or through self-laceration, and taken together, those are about 3% successful. It's just the incredible lethality of guns and snap decisions that I think put people at risk. Dr. Ellison.
I'm a retired general surgeon. I was in Vietnam. I was in Oakland County Hospital, Island, for 5 years. I was in the Fresno at the county hospital for 7 years. Saw many penetrating injuries, and I also lived in Australia for 3 years, where I saw no gunshot wounds, and I lived in Japan for 2 years and saw no civilian injuries that were caused by gunshot wounds. So this is a uniquely American problem. However, the one thing that I don't think you've addressed is assault weapons. Assault weapons, there's no excuse for civilians to possess assault weapons. I've had guns ever since I grew up. I've been a hunter all my life. Well, up until the past few years. But hunters don't need assault weapons. They don't use assault weapons. You don't shoot 200 times at a deer that's escaped after the first shot. So assault weapons, talk about low-hanging fruit. Assault weapons are the low-hanging fruit. In fact, they were illegal up until a few years ago in this country. And I think that's the first thing that needs to be addressed. And the NRA, actually the NRA taught me how to shoot when I was 6 years old. And I was a member of the NRA for many years, up until, I'd say, 10 or 15 years ago, when I saw they were becoming politically involved. And now I think they are detrimental from their political involvement. So I think that issue needs to be addressed as well. We have to get rid of assault weapons.
Thank you for that comment. I also grew up shooting. I grew up on a farm here in Central California, and we used to shoot gophers and coyotes that were getting into the crops and coming after the animals. So that resonates with me as well. And the Western Trauma Association actually put out a consensus statement calling for a ban on assault rifles in February of this year, and Dr. Schatz and Kokenauer were instrumental in making that happen.
One other comment I forgot to mention is that Americans Against Gun Violence is an organization here in Sacramento. Bill Durston, Dr. Bill Durston is the organizer, and he was also in Vietnam. He was a Marine in Vietnam, and he has been very instrumental in trying to organize gun violence nationwide, gun violence prevention nationwide, and I think if we want to get involved, he should be part of the involvement.
Thank you.
Dr. Galante, and then Dr.
So, next way back to Dr. Boyd's point about where you would invest the money. So it sounds like you have a lot of statistics, but really in order to know where to invest a big bulk of money, as opposed to relying on anecdotes and emotional pleas and things like that, we really need to have the research.
Absolutely.
I mean, there's questions that we assume we know answers to
Yeah.
that we don't have any data on.
Absolutely.
So while we are blessed to have research being able to be conducted here through Dr. Wintermute, what is the solution to that? Because really to make this a bigger argument, you bring data to the argument,
Yeah.
And we need money to get data. So what do you foresee as the issue of research being able to
So as we talked about, the Dickey amendment has really had some pretty chilling effects on the funding pool for gun violence research, and I think that that's an important point that the professional organizations we're all part of can bring to the table. We have lobbying efforts through the American College of Surgeons, through our trauma organizations, and I think the thing to do is there's a political freeze on funding. I think that has to be a political response, and what we can do is we can say, yes, as a group, this is important to us. Yes, these are the things that are happening, and bring it to our representatives. Nothing will happen if we don't talk to the people who make funding decisions. And so I think individually, if anyone's interested, or as part of our professional organizations, we can reach out to the people who make funding decisions to get that to happen, because I agree, the best decision is going to be an informed one. And I mean, if it turns out the research shows giving everybody a gun makes the world a lot safer place, let's do it by all means. I just think that we need to have some answers.
McGee, our last question.
So having the moral upper hand and being in the right side of this discussion, unfortunately, is not going to change legislation. It is going to be lobbying dollars that are going to change it. When I've been to Washington, lobbying for a fundless cause that was quite important, and basically no one listened.
Yeah.
But if you do show up with real lobbying dollars, so what we're going to need, the cars got better because if you sell a less lethal car, you outdo your competitors. That was natural, but you're not going to sell a less lethal gun.
Yeah.
No. Ultimately, we're going to have to partner up with the vault makers or someone else who has a financial interest in making things safer. It's not going to be the NRA.
Well, I think the NRA, that's a great point, and I think if somehow the NRA were able to take hold of the discussion and really make a call for appropriately funded gun violence research, that would go a long ways, but I'm not sure it's going to actually happen. But I think we need buy-in from multiple players. I think it's going to take a number of different people and from different walks of life with different opinions. I think it has to be nonpartisan. It has to be a group of different people with different ideas and different interests who really are interested in finding the truth, and that's going to take a lot of us.
If you make a device that makes money by controlling guns, you'll be in business. Until then.
Well, provocative as always, and Jim, thank you
Thank you.
for your last 7 years, and we look forward to the next ones.
All right. Thank you very
All
much.
right.